heard about MTSS, medium-term sector strategy. And I was wondering whether we are making comments based on what is still going on or things that were in the books. Because I recollect having asked the Minister of Finance and the Refugee Budget Office why they are no longer doing MTSS, by my own understanding. And they clearly told me about 2 years ago that the transformation agenda has taken the place of medium-term sector strategy, so they stopped it. That all they did was to look at Vision 2020, a lot of high-level national development plans, and use it to construct the transformation agenda. So that if they've done it once, what's the need to do it? Please, I would love to clarify if the Ministry of Health is still doing medium-term sector strategies, and if they're still doing it, who are the stakeholders involved in crafting it? Because some of us were involved so many years ago, around 2006, 2007, in doing preliminary training for some MDs about how they can go about medium-term sector strategies, and they know the plethora of stakeholders that are involved beyond the ministries and their parastatals, private sector agencies, committee with oversight in the National Assembly, organized level, organized civil society, and just the whole hunk of people that once all those stakeholders on board, professional associations, and you finish, is as good as saying it's ready to go because everybody who should be there is in the room.
Thank you. Thank you, ma'am, for your wonderful comment. Actually, this issue of joint allocation is a problem, is a challenge. The reason for that, viewed from the point of rationality, is not quite clear. Because if we say, and we agree, that the local government is a tier, the state level is a tier, and the allocation for the state is not jointly managed by the federal government and the state. The same thing should be replicated downwards, whereby the allocation for the local government is not jointly managed by the state. And even that jointly can be qualified. When you are managing something jointly with someone, you have a significant say. You think carefully and you wonder if this significant say is equitably operating between the local government council and the state. So there's a problem there. What is the solution? We are talking about having to take action beginning from now. We are talking about having to do something beginning from now. All stakeholders, we all need to join hands to ensure that whatever is due to every tier goes to that tier as approved. And then we can hold them accountable. Otherwise, if you go to the LGA council head now, or chairman now, to try to get him to account, you will find it a bit difficult. Because the first answer is going to tell you is that, well, we got something for salaries or whatever. Yes.
That's all they get.
Yes. So with that, it was a challenge. But we need to, it's beyond the authority and mandate of MPACP to enforce that particular challenge, to address that particular challenge. But it's not in that regard, quite frankly, you are in a better position to advocate for change. Then blood transfusion at the primary healthcare facility. Please, I would like to refer that to our distinguished colleague, the representative of the Society of Physicians and Gynecologists. I would like him to make a comment on that. Permit me to make that referral. Then MTSS, by design, medium-term sector strategy is what MTSS stands for. It's a situation or a process whereby plans are developed for the forthcoming 3 years, beginning from the year after the process is taking place. And it describes the key projects to be implemented, the results that are expected, both at the output as well as the outcome levels, and the resources required to implement those by the projects. And so it is expected that when appropriation is released, it will be based on what has been developed for each project for that year, and it's like that for 3 years. So what we are saying is that there's a disconnect between what, as an example now, if it is routine immunization, we say in 2015, what is required for routine immunization is X amount of naira or dollars. The appropriation that we made for 2015 should address just that, or at least that. And then the release should be 100%. But that is not happening for a variety of reasons, including funds availability to the economy and the rest. Yes, the MTSA that was developed in 2012 supposed to cover 2013, 2014, 2015. And ideally, every year, if people get together for MTSS, it will need to be just a revision of what has been done earlier, based on the non-stability of exchange rates and other economic factors that were affected. But I agree with the last question, the person that had the last question, the team leader of Center for Social Justice, that I'm aware that MTSS sessions did not hold last year.
Sorry, sir, but what you are saying, the one prepared in 2012 is still the one being used.
No, see, I have already said that even when it was being prepared, the appropriation did not address it. So the question of it being used may have been silently addressed by those comments.
Okay, so that was the last time you did it.
Okay.
All right, thank you. Which one? The referral is mentioned. Are you the referee?
No.
Not in me. No, where is the person saying I will do something?
Someone here.
The person who he referred to.
Yes.
To be honest, I didn't appreciate your concern. Can you just say it again so I can be specific?
I asked if blood transfusion and cesarean section could be done at the health center level, the primary health center level. Okay, if it could be done there, that there are doctors, qualified doctors who move from the tertiary level down to that level to do that. But the equipment, like for emergencies, are not available at those lower levels.
Yes, I think you said it all. The facilities at the primary healthcare level is such that you will not be able to carry out some of those functions at that level. And that is why you have what we refer to as basic emergency basic emergency obstetric care and the comprehensive obstetric care. The comprehensive care, those are the ones that involve the cesarean section, blood transfusion, anesthesias. Those are the ones you have to do at the comprehensive health center that is beyond the primary healthcare center. The comprehensive healthcare centers are more like the secondary healthcare facilities. And the primary healthcare facilities are usually at the lowermost level, where what they do most of the time are basic services that do not involve operative interventions to the level of a cesarean section. So the structure as it is now is that there are no provisions on ground at the primary healthcare level for you to carry out those functions. And it is recognized that people who work at that level will identify cases that need to be managed by operation and reflected. That is why we now have in most of the centers, you have this hub and spoke arrangement, like in the MSS system, where you have 4 primary healthcare linked up to a general hospital, and it's expected that the cesarean section and blood transfusion will take place at the general hospital or the comprehensive center, while the primary healthcare centers, they identify such cases that will need that intervention and refer them. I think it's like a cascade that has been developed, and if we can actually build it all over the world, there are no places where major surgeries are taking place at primary levels. Like even in the United States, Britain, where you have the primary healthcare physicians are the GPs, are their satellites and where they operate in their surgeries. They don't do operation there. They even know they are doctors. Some of them are even consultants, but they don't do operation there. They identify the ones that need to be operated and refer to the general hospitals where those services and the facilities are there to undertake such services.
Ezra, can I ask you one question for you? Okay. Sorry, my questions have always come a little bit late. Thank you, National Primary Healthcare. We have found that funding at the local government level for PACs is a major challenge. At a time, there was this policy that states should have state primary healthcare development agencies, without which funds will not come from national primary healthcare to the state healthcare services. Now that you are going to get a big chunk of the consolidated revenue.
Just 1%, it's not big.
Better than zero where we are coming from.
1% of CRF is a
big money.
consolidated revenue for 1% of it is
not more than
enormous.
Now, they take my time.
Eh?
Now, sir,
It's what?
don't you think that you should enforce that policy that no funds for primary health care will go to state government except they have state primary health care development agencies, and or copy what SUBEB, Universal Basic Education, have done at state level? They call them SUBEB. They no longer pay teachers from state posts, and that's why many of the local government are crying, because they pay teachers from the National Universal Basic Education direct, and so teachers are on ground. Can't you pay our nurses, and particularly your MSS nurses that are compromised by the state governments?
Well, sir, this is getting more and more interesting. But when you recommended UBEC, if you look through, you'll also find there's a problem. There is over, as at the last count, there's over 45 billion naira unassessed funds lying there. States are not able to assess. And the funny thing is that the states with the worst education indicators are the ones that have not been able to assess their funds. Because they tell them if they give you money, you have to retire and show that you use it well. And then there's counterpart funding before you collect a new one. So that model may work in some ways, but if you do that to health, money will be there, nobody will.
Thank you. I want this last question, but first let me just emphasize on the point that came before the last. I made that reference to the expert here for the purpose of emphasis, and I think we laid significant emphasis on that point in terms of cesarean section at the primary care level. Somehow, really, it will be seen to be like a disservice when a doctor in a teaching hospital or a general hospital located far away is encouraging the conduct of cesarean section operation in a distant health center, because somehow to contribute to some delays, because if there's a problem and the nurse make a phone call, doctor, are you on your way? And they say, I'm coming. If something happens to his vehicle or his means of transport and he's delayed, people will be waiting. And under that circumstance, a second matters. So it is actually not allowed for that to happen. That's where there is the provision of referral as a critical component of primary health care. He has emphasized on it already, so I will stop there. We don't encourage it at all. Then in terms of, so thank you for that assistance. Great. Now in terms of the enforcement of that condition, that without the establishment of a state primary care board, there will be no utilization of the funds that are accruable from the Health Act. I think it is, please correct me because I'm going to your domain now, many of you. I think it is implicitly implied by that act when the act said that the disbursement will be to the states through the State Primary Care Board. Somehow we are empowered to hold on to that and make the condition of having an effective State Primary Care Board, the disbursement contingent on the State Primary Care Board. And it's not difficult to have it established. Quite a number of states have established already, although the degree of effectiveness varies from state to state. But we, along with stakeholders and you, because in non-governmental organizations, you have a role to play in that also. You have a role to play on ground. That is one area in which you can also collaborate with us. Working with you, how can we make sure that certain things happen at the state level? Like I said earlier, there are ways and things you can go and tell the governor that I cannot go and tell the governor, or at least the commissioner or the state health personnel cannot go and tell the governor some of the things that you can say to the governor. Or the commissioner for health, what you can tell the commissioner, the director in that ministry cannot say it to the commissioner. So all of us have a very important role to play in these important key areas that have come up for discussion today. I am hopeful that everyone here, based on what I have heard and the concern that has flowed steadily, that everyone here is prepared to be part of that small group that we are talking about, that small group of thoughtful, committed persons who can change this country. I thank you very much for this great opportunity.
Well, we have to thank our facilitator and end this session. We'll proceed for lunch. Lunch is served in the restaurant for 1 hour.